Hello, everybody. Hi, Dr. Nasser.
Hello.
Can you all hear me clearly?
Yes,
okay,
we can.
Okay, wonderful. All right, so welcome everybody to the third and final session for today. I'm Dr. Maysam, and I'm going to be moderating this session. First of all, I'd like to thank Professor Aisha Bahri and Dr. Leila Sheikh Ismail for the opportunity to moderate this session. And we will start the session with a talk from Dr. Nasser Ibrahim about oxylipins and polycystic kidney disease health risk. To introduce Dr. Nasser briefly, he's currently an assistant professor at the United Arab Emirates University in the College of Medicine and Health Sciences. He joined the UAE University in September 2019. And before that, he was a senior research associate at the Manitoba Center for Health Policy. And he was also an instructor at the University of Manitoba, Canada. Dr. Ibrahim completed his PhD in Human Nutrition Sciences at the University of Manitoba in 2015. And he also completed his master's degree in Nutrition and Dietetics at the University of Toronto, Canada. He has extensive research experience in public health and nutrition and biomedical research in areas of nutrition, oxylipin, and kidney disease. Please welcome Dr. Nasser Ibrahim. And you have 20 minutes on the clock, Dr. Nasser.
Thank you. Thank you so much. Yeah. Thank you, Mayas. Thank you. Let me share my screen. Can you see my presentation now?
Yes, we can.
Okay, thank you so much, Dr. Mason, for the introduction. First of all, I would like to thank the organizing committee for the conference and the chair of the organizing committee, Dr. Aisha Tahiri. So today I will be talking about oxylipin and polycystic kidney disease. Basically the role of oxylipins and lipid metabolism in kidney disease. We will be using a model of polycystic kidney disease. These are the outlines for my presentations today. I will give you a little bit of introduction about the topic and the background that took us to the rationale to conduct two studies. So I will be sharing with you the results of two studies, study 1 and study 2. And we will go over to the conclusion of the two studies, the significance of the research and future directions. So I would like to say that I have no conflict of interest, and the two studies were funded by the Canadian Institute of Health Research. So as you know, polycystic kidney disease is basically a genetic disease that's caused by mutation in either in one of two genes, PKD1 or PKD2. Despite the fact it's a rare disease that's affecting only 1 in every 500 to 1 in every 1,000 individual. However, 10 to 15% of the people who have end-stage renal disease, it's all actually caused by polycystic kidney disease. The disease is characterized by abnormal cyst growth, interstitial inflammation, and fibrosis, which eventually lead to renal failure and death. As you can see, there's multiple cysts on the outside and the inside of the kidney, which will affect kidney function, leading to renal failure, end-stage renal disease, and eventually death. There is no actual treatment for this disease rather than the dialysis or controlling the complication caused by the disease, such as high blood pressure. However, diet has been shown to play a very important role in reducing the disease progression of this kidney disease. Specifically, altering or changing the source or the dietary source of lipid and protein, for example, dietary soy protein, fish oil, and flax oil have been shown to actually reduce the disease progression and improve kidney function. We think that one of the mechanisms that dietary soy protein or lipid reduce kidney disease progression is mainly through altering the fatty acid composition of the kidney and then eventually altering the oxylipid metabolism within the kidney. As you know, oxylipins are signaling molecule that play a very important role in kidney function and process in the normal state and in the disease state. In the disease state, they can mediate inflammation and they can accelerate fibrotic process. So the whole research program that we are conducting is trying to understand the relationship between diet, oxylipins, and kidney disease progression, how the disease alters oxylipins and how oxylipins can be altered by the diet and how is that affecting kidney disease progression in a rat model of polycystic kidney disease. As you know, when the cell membrane or the cell is exposed to different effects of physiological or pathological effect, the arachidonic acid can be released from the cell membrane. Arachidonic acid, as you know, omega-6 fatty acids. When it's released from the cell membrane through the action of phospholipase A2, arachidonic acid can be further metabolized into through three pathways of metabolism: the cyclooxygenase, the lipoxygenase, and the cytochrome B450 pathway of metabolism. The most studied one is basically the cyclooxygenase pathways of metabolism, where prostanoids are produced. So specifically prostaglandin D2, prostaglandin E2, prostaglandin F2 alpha. And these are basically mediator of inflammation. We will see how these will change by disease. While the lipoxygenase pathway will produce mainly lipoxenes, and the cytochrome B450 will produce mainly epoxoids. However, oxylipins can also be produced from omega-3 fatty acids, including icosapentaenoic acid or EPA, DHA, and alpha-linolenic acid, which are all of them are omega-3 fatty acid, producing a different kind of metabolites that actually have an anti-inflammatory effect, which we propose that they could actually reduce kidney disease progression. So if we are supplying diet with fish oil, we will be changing the fatty acid composition of the kidney, increasing the levels of EPA within the kidney. This will alter the metabolic pathway of arachidonic acid because EPA will actually be competing with arachidonic acid for the phospholipase A2, and also it will be competing for the two enzymes, the cyclooxygenase enzyme, cyclooxygenase 1 and cyclooxygenase 2. Therefore, the EPA will produce an anti-inflammatory icosanoids or prostanoids, specifically prostaglandin E3, thromboxane B3, and prostaglandin I3, which we call them the three serious icosanoids or prostanoids. And these can actually reduce disease progression of the kidney. Also, the other pathway that can be affected, the lipoxygenase pathway. This will result in producing more of the 5-series leukotriene, leading to production of less pro-inflammatory oxylipin produced by arachidonic acids. In previous studies, we have shown that in diseased rats, as you can see on the right side, these are the diseased kidneys, the level of thromboxane B2, prostaglandin E2, and 6-keto prostaglandin F1 alpha are higher in diseased kidney compared to normal kidneys. So the disease does alter the level of these prostanoids by increasing them. However, when we fed the rats with dietary soy protein, actually soy protein reduced kidney disease progression and altered the effect of disease on these prostanoids and reduced them, which was associated with improvement in kidney function. In another study, in cell culture, this study shows that the prostaglandin E2 and prostaglandin I2 actually can stimulate cell proliferation, fluid secretion, and cyst formation, meaning that they could actually, every time you're adding more of prostaglandin E2 or prostaglandin I2, you are increasing the size of the cyst, contributing into disease progression. Therefore, if we can reduce the level of these prostanoids, we might be able to reduce disease progression. In another study, selective inhibitor of the cyclooxygenase 2 pathways, one of the pathways that metabolize the arachidonic acid to produce these metabolites, if you block it, this will ameliorate the alteration in prostanoid production, which is related to disease progression, and reduce the disease progression. That's selective COX-2 inhibitor. However, we don't know what's the effect of inhibiting both COX-1 and COX-2 like aspirin does. So what we really want to know, this is the pathways of metabolism. We wanted to understand the effect of dietary soy protein and fish oil in cystic kidney disease and on prostanoids production, as well as the production of oxylipins from the three pathways, cyclooxygenase, lipoxygenase, and the cytochrome P450, and how is that actually related to disease progression. So that's the objective, to understand the relationship or the effect of dietary soy protein fish oil on kidney disease progression and renal oxylipin levels and fatty acid composition, as well as the level of the COX enzyme using a hand-spread dual cyst model of polycystic kidney disease. The hypothesis for the first study, we think that the level of the N6 cyclooxygenase products will be high in diseased rats, and the level of LOX or lipoxygenase products will be low in diseased rats. However, if we feed rats with soya protein and soya oil, we will be able to blunt the effect of disease on oxylipin production. This will reduce inflammation and reduce disease progression. The effect of dietary soya protein, we think, will be further enhanced if we add fish oil, because that will change the fatty acid composition of the kidney, replace arachidonic acid with EPA, leading to a production of less pro-inflammatory oxylipins, and that, of course, will reduce disease progression. So that's the study design. We included 70 male rats. They were 3 weeks old. We genotyped them, and then we distributed them into four different diets. The standard AIN93G diet, which has casein protein as the main source of protein and soya oil as the main source of lipid. And then we switched the soya oil with fish oil, and then we switched both the protein and the lipid. Now we have soya protein and soya oil, and then we switched the soya protein, the soya oil with fish oil. So now the last one is, we expect this to be the best group in terms of effect. The study continued for 8 weeks, and after which we terminated the rats and collected their kidney and blood for measuring kidney function. These are the things that we did with the tissue. We measured the level of oxylipins using HPLC, tandem spectrometry, or tandem mass spectrometry. We measured the level of enzymes, Western blotting, the fatty acid composition with gas liquid chromatography, and the disease progression using histopathology. So this is the result for histopathology for the first study. As you can see, this is the green groups here are the one that has soya protein with soya oil or with fish oil. As you can see, for the cyst volume, the group that have received the dietary soya protein and fish oil have lower cyst volume compared to the one that has casein protein with soya oil. So lower cyst volume, that's mainly a protein effect. And then lower fibrosis volume as well. As you can see, when we looked at the cyst volume in the medulla mainly, we see that the cyst volume was lower in the soya protein soya oil and in the soya protein fish oil compared to the casein protein soya oil. And also fibrosis, the effect of fish oil was stronger on the fibrosis, meaning reducing inflammation. The white area here in the picture, as you can see, I don't know if you can see the mouse, the white area here are the cysts, okay? As you can see, they are very big before the intervention. Once we supply or change the diet, changing the fatty acid composition, the cyst size will be reduced. When we looked at the kidney function, we found that these are the diseased rats on the right. The left is the normal rat. Of course, the diseased rat will have, for the standard diet, will have higher serum creatinine, so they're losing kidney function, and they have higher serum cystatin C, they are losing kidney function. But when we give them soya protein with soya oil or soya protein with fish oil, cystatin C, serum cystatin C and serum creatinine were reduced, okay, indicating that the dietary soya protein and fish oil reduced disease progression and improved kidney function. When we looked at the fatty acid composition, the group that received the fish oil, as you can see, EPA and DHA in the fish oil group were increased. So we were able to change the fatty acid composition of the kidney, and therefore we changed the composition of the cell membrane itself, and therefore we can, or we were able to change the metabolism of arachidonic acid and the oxidant production within the kidney. So now this is very interesting. If you look at to the right, the CY group is the diseased group and the plus is the normal group. As you can see, this is the standard diet. The first blue one in the diseased rat have very high level of prostanoids in general, 6-keto-prostaglandin F1 alpha, thromboxane B2, and prostaglandin E2. As you can see, they are higher in diseased rats. However, when we give them the soya protein or the fish oil in green, or even the fish oil here in this group, the effect of fish oil here, you can see that thromboxane B2, 6-keto-prostaglandin F1 alpha, and prostaglandin E2 actually were reduced. So we blunted the effect of disease on these prostanoids. And therefore, these are markers of inflammation. We were able to reduce inflammation just by dietary intervention. And now, if we look at the—
Sorry, Dr. Ibrahim, I'm sorry to interrupt. We have 3 minutes on the clock.
3 minutes, okay. So now, if we look at the level of the 3 series oxidants, these are 3 anti-inflammatories. The level is higher in the fish oil groups. Okay, so we'll not be talking about the lipooxygenase. So in conclusion, dietary soya protein and fish oil actually reduced the level of elevated COX in the diseased kidney and also changed the levels of lipooxygenase products and reduced kidney disease progression. I will not be able to share with you the aspirin study. However, the overall conclusion, dietary or pharmacological inhibition of the cyclooxygenase product without inhibiting the lipooxygenate product will have the potential to treat this disorder. Okay, we think the study is very important because this is the first study to look at metabolites from the 3 pathways of metabolism. We can actually reduce the disease progression using just a dietary intervention. Okay, and the study demonstrates the potential of these inhibitor in treating the disease. We wanted to see the effect of different doses of aspirin. I didn't explain the aspirin study, but we wanted to see the effect of different doses of aspirin on kidney disease progression, because we have demonstrated that a small dose of aspirin actually can reduce the production of the cyclooxygenase product and reduce disease progression. So I would like to acknowledge all the funding sources, and thank you, and thanks to the organizing committee. Thank you.
Thank you, Dr. Nasser Ibrahim, for the wonderful presentation. We will leave the questions until after the three speakers finish their lectures, and we'll move on to the next speaker. The lecture is going to be about the importance of body composition analysis and how to read the results in treating your patients. This will be delivered by Ms. Razan Shwayhat. Razan Shwayhat is a registered dietitian in Jordan and UAE. She studied nutrition and food processing at the University of Jordan. She's a member of the Board of Trustees at the Royal Health Awareness Society, which was established under the direction of Her Majesty Queen Rania Al Abdullah. Razan is also a well-known media figure. I think everybody knows Razan or has seen some of her interviews. She has covered nutrition segments in several TV programs, such as فنجان قهوة, أسرارها, الأسرة العصرية, and she is currently producing and presenting her own cooking show and competition for weight loss and nutrition segments at Ru'ya TV. She's also an author of a book. She published it in 2015, entitled غذاؤك صحتك, which means your food is your health. Razan, the floor is yours, and you have 20 minutes on the clock.
Thank you, Dr. Maysam, for the introduction. It's my pleasure to be here with you at the IGD conference. It's not the first time I attended, of course, and always delighted to be part of it, whether as an audience or also as a speaker. So today I'll be talking about body composition, and one of the measures that we use usually to detect the requirement and the body composition and all of these things. So I'm going to start firstly by sharing my screen. Okay. And here we go. 1 second, please. Can you see my screen?
Yes, we can.
Okay, great. So basically, we're going to talk about the body composition analysis and the different ways, firstly, that we are using to analyze the body composition. But firstly, what we're going to learn from today's presentation, the types that are available to analyze the body composition, and to recognize the importance as well of the BCA and how to apply it in our medical assessment and in treatment, and how we're going to reflect these results and the analysis on the patient themselves, which will help us as well to set the goal and the current status of our patients, and at the same time, how we're going to be able as well to use it more in research. So the topics I'll be covering will be the types of the BCA that is available and the difference between BMI or body mass index and bioelectric impedance analysis, and how we're going to use them in different health organizations, and how to get accurate results, because even if you have the best machine, but we don't put it at the right status, we don't get the result that we want, what to look for in the result sheet that we get from the analysis, and how we can apply the body composition analysis in much more than just weight management, in nephrology, cardiology, diabetes, pediatric, geriatric, and sarcopenia, and many others, and which will help us as well to set the goal based on the body electric impedance. So we all know that usually we have two types to detect or to analyze the body composition. One of them are direct methods, and we have the indirect methods. Direct methods can be as accurate as the underwater weighing, or the computed X-ray, or the magnetic resonance MRI, and many others. Whereas the indirect method starts from a basic anthropometric measurement using the body mass index, height to weight, skin fold, waist to hip ratio, not to underestimate them, but they are one of the indirect methods. And at the same time, the bioelectric impedance, which will be the main topic that we will be covering today. So basically, we all know as health professionals and dietitians that body mass index is just a relation between the height and the weight. And there are a lot of index and a lot of research that has been done to really get the best measures of the BMI. And we have the BIA, which is the bioelectric impedance. 1 second, I want to reduce this. I don't know how. Okay, anyway. So the body composition methodologies that are used, which is regarding the body density tissues, concentration of electrolytes, fat, and muscles, which also take us more into the body components and body tissues and their distribution as well. So if we look at the pros and cons, like why are we looking at other ways of analyzing the body? Why don't we just go for the BMI? It is very easy to use it. It's inexpensive. There are a lot of reference data for the body mass index, and we can use it to treat obesity, especially that we can track the change of a 3.5 kg needed to produce a 1 unit change of body mass index. In adults, it's also used. Any measurement above 25 is considered at a risk of obesity and weight gain and mortality. Whereas in children, body mass index, of course, is taken into taking a different measure where we use the percentiles rather than just a number for height and weight. The cons, of course, we cannot use it for athletes because it does not tell us what is that extra weight, and usually athletes has extra weight, but it's mostly muscle mass. For persons with some medical conditions like the sarcopenia, where the weight is altered by changing proportions of muscles as well, and definitely for pregnant mothers because the extra weight is the baby weight and the pregnancy weight as well. Whereas let's look at the bioelectric impedance and the pros and cons. Of course, the most important thing is that it takes into account the person's height, the person's weight, body type, gender, age, activity level, fitness level, all of these things. And it can help us to allow for early detection of an improper balance of body composition, which will help us as well to foster early intervention and prevention rather than wait till we see really an extra body weight. Not only that, it also gives us a clear idea of the fluid and the body mass, which can be a critical tool as well, which we will talk about more in details now to assess the current state of health. As for the cons of the bioelectric impedance, sometimes it's hard to assess it, especially with very obese people, as the proportion of the body mass to body water is different because the hydration level of the fat-free mass is lower in the obese people, and the measurement of the bioelectric impedance depends a lot on the extracellular, intracellular water that is also changed in the obese people. So nevertheless, it's still one of the most favorite, and now every dietitian's office has a bioelectric impedance, whether a basic kind or the advanced one, and we rarely go back to the body mass index as a tool to determine the overweight and health and all of these things, which we will also concentrate on. So we started seeing it mainly in the dietitian's clinics. Nevertheless, in hospitals now it's more available. Gyms are now they understand the importance of the bioelectric impedance. Corporates now, especially big companies, now take it as part of their health and wellness for their employees to have the BIA in their offices, and schools as one of the things, especially for kids, as we say, because we want to detect it earlier when it's a hidden obesity rather than to wait when we see it on the body of the kids as well, which will be harder afterward to help them lose weight. Now, in order for you, because sometimes we hear that we're not getting good results, the results are not accurate, they are changing, sometimes the results are confusing. You have to make sure that before the test, there shouldn't be any exercise. So many times I have some false result because the patient has been exercising for like 1 hour and they come to test, they're sweating or drinking water. Changes in water balance does affect the reading. So therefore, no food or drinks, preferably before 4 hours of the test. And it's also preferable, as we know, to test at the same time. So if they come to your clinic every day in the morning, then every measurement preferably will be in the morning rather than one time in the morning and one time in the evening, because we know that by the end of the day, water accumulates, gases and stuff and digestion, so the number will be different. Of course, for females and during menstruation, because we know that the water content differs during these period of time, and pregnancy, because we have a lot of fat tissues as well, which make the reading not so clear. And some people, when they have a medical devices, we may not get also the accurate results that we want. So we tested, we took care of all the measurements before the test. Now we have the results. In the result sheet, you may see a lot of information, but what do you need to look at when you see these information? So the first thing we look at is the body weight. So we look at the height, body mass index, waist to hip ratio. We look at the body fat mass. And here we need to look more into not just the kilograms, but also the percentage. And most importantly is the segmental fat analysis and the visceral fat. And Dr. Usama Lalla has been talking before also about the importance of visceral fat and how we need to look at reducing it to reduce the risk of health diseases as well. Muscle mass, again, we look at total muscle mass in kilograms and segmental lean mass. Don't underestimate water, because we need to look at the total body water, intracellular, extracellular, even the relation between the ACW and the total body water. So these results are all in one sheet that you get from one test that does not take more than 3 minutes. But reading the report for your patient is very important. And as I said, we will be talking about weight management, cardiology, diabetes, oncology, nephrology, pediatrician, even ICU, disease prevention, geriatric, corporate wellness, nutrition, and many more others like personal training. So today I'm going to concentrate mostly on how we're going to benefit from BIA in weight management, cardiology, diabetes, and pediatrician as well. So first of all, what we need to look at for the weight management, how we're going to apply the results. First of all, what information do I get and how it is helpful? It's firstly helpful because it will help us to monitor not just the weight, but also the muscle mass, the percentage of fat, and the client will be able to also track and maintain their ideal body composition. And here we can distinguish between muscle mass and fat loss. We also can get accurate and objective measurements to also evaluate the success of the client based on their body composition. And based on that, we also can give a better advice for a dietary intervention. And also, when we look at it, it will give us a clearer idea of the BMR, the basal metabolic rate, which is mainly when we do the test, it will give us results based on the body composition of the person rather than general equations. So these are examples, and the main thing or the main key message that I want to get out of this presentation is that we need to educate our patients. We want them to speak our language. I see them a lot talking about body mass index without understanding what is it. When they step on the scale, they tell me, yeah, you're going to test the BMI. No, I'm not going to test the body mass index. Body mass index is just a height and weight. I want to look more into your body. So the message is educate the patient, let them speak your language, let them talk about body composition, not body weight. And honestly, I love the result when at the first visit, the patient is telling me how many kilos I need to lose. After the third, fourth session, she started asking me how many fat kilos I lost. And even if I tell her you lost 3 total kilos, she asked me again, how many of them were fat? And this is something very important as well that we need to look at. I'm trying to minimize this so I can see the side of the presentation, but I don't know why I cannot. Anyway, so in this screenshot, it shows also how one of the patients had a lot of weight, had a good amount of muscles, and had a lot of fat. So during the diet process, we were able to reduce the fat mass to 23 kilograms out of a total of 26 kilos. And we tried to preserve the muscle with only 1 kilo. And this is where I start educating the patient about the result and to look more into how their sizes are different, how the body shape is different, and all of that is coming from losing more percentage of body fat rather than just to concentrate on how many kilos I lost. Another also important message that we want to tell our patient is why we dietitians concentrate a lot on the body fat and losing body fat, because of course how it is affecting their health, and that's why they start seeing positive results from weight loss. Although most of the patients sometimes want to lose weight just to get a better body shape, but again, it's our job to educate them more and more about why we need to lose the body fat to improve our health, and of course eventually the weight will be lost. So we all know that body fat affect, and so many research has been done about the adverse effect of high amount of body fat to increase risk of high blood pressure, cholesterol, type 2 diabetes, other coronary diseases, gallbladder, osteoporosis, even the little sleep apnea and the breathing problems at night, inflammation. And we know that most of our diseases are mainly caused by high level of oxidative stress and inflammation that even can lead to some cancers sometimes. The quality of life is affected by high amount of fat, mental health, depression, and all of these things, plus the body ache and the body pain and the difficulty in functioning. All of these come not just from extra weight, because if you have extra weight as muscle mass, you will not see all these side effects. But when that extra weight is fat, you start seeing all of these negative effects. Another thing we want to educate patients about it, which is the visceral fat, which they call it thin outside, fat inside, because sometimes you may have an ideal body weight, you may have an ideal body fat, but the fat is distributed not evenly in the body, or you see more of the visceral fat, which is the fat that surrounds the organs. And this is the most dangerous fat, though you don't see it by eyes. And it has been really also research to be directly related to many diseases from heart, diabetes, and even Alzheimer. So we also start showing them how their visceral fat is affected when they're losing weight, how their waist is also getting better, and losing more of the abdominal fat as well, which is also one of the main factors for insulin resistance also. Another thing, just like we educate about the negative effect of fat, we need to educate them about the positive effect of muscles. This is a very interesting screenshot of one of the clients who came to me, a mother with her daughter. She came for her daughter, not for herself, because she thought that she's within the ideal body weight. Her normal body weight is amazing, so she's feeling okay and she doesn't need to do anything. I triggered her to do the body composition analysis, and she was surprised when she saw that she has a very low amount of muscle mass and a high fat percentage. So though the body mass index showed 20, which is a normal range, her weight is in the normal range, but her muscle mass was too low. And she was in her late 40s, which means if she continues like this, and we know that as we age, we lose more of the muscle mass, she will be at risk of unhealthy aging because of losing more of the muscle mass. She started working out, and I started, this is the same result for the same, no, another lady. I have another screenshot for her where she started increasing her muscle mass and losing her fat. She started working out, taking care of her diet, and her results were shifted, though the weight stayed the same, but body shape and health-wise, she was feeling much better. This is another boy, and we talked about also kids and how it's important for them to look at the hidden obesity. This is the other way around. This boy thought that came to my clinic because he wants to lose weight. His body mass index shows that he's overweight. He looks at his weight compared to his friends, and he thought that he's overweight. But when we did the body composition analysis, we found out that this extra body weight is actually muscle mass. His fat mass is way too low, and he was so happy about what he's doing and continued exercising well, and started even advising his friend that he's not fat, he's not overweight, it's muscle mass that he has. So that's one of the main thing that we look at for weight management, and also for nephrology. So nephrology is a very important and critical part where we need to use more the body mass for the bioelectric impedance, because we can get more objective results of the fluid measures. So we can get also a guide to a goal weight management. And when we have this goal, we can also assess the nutritional intake based on it so as to prevent the muscle loss and to make a better changes in the body. And at the same time, it will help us to evaluate the fluid, and fluid is a very critical and important issue in nephrology. So we can see here that this is one of the patients who had a high water retention before the dialysis. And this is where we see on the right side how after the dialysis he lost. So this is where we need to check if the dialysis was enough and it was convenient, and we got rid of all the water, especially in the lower legs and the trunk as well. Am I on time?
Sorry to interrupt, Razan. Yes, 2 minutes on the clock.
Okay, great. So also another thing as well is not just to look at the water in the for the nephrology, but also to identify the circulation issues. So we want to make sure that there is no water retention in the legs, and so we don't see any side effects, and we make sure that the nutrition plan that we're following is good and the dialysis as well is going right. Cardiology is another important application for the BIA because we can assess the cellular health, and this is something very important. I'm going to now explain it. Improve the quality of the cardiac rehabilitation, especially after cardiac surgeries, and to diagnose or detect earlier any circulation issues related also to the disease. There's something very important if you have seen it in the test, which is called the whole body phase angle. And this is a very important thing to look at it because it's a measure of how the cell responds. It's to the electrical current, which also gives us an idea about the cell membrane integrity, which means in very simple word, are we having healthy cells or we don't have healthy cells? And especially with heart patients or cardiology, we really need to make sure that the cell membrane is working properly, and it means it's effective and there is no damage, and the nutrition that we're giving is also appropriate, that is keeping the strength of the cellular membrane. And also not to underestimate the edema. So we need to look at the intracellular water, extracellular water in comparison to total body water, and also to the segmental body water in every body part. So we make sure that the cardiovascular function is effective. And usually when they are taking diuretics, that it's also giving the effect that we want. And sorry. In diabetes as well, it's very important because we are at a risk of losing the muscle mass because of improper nutrition. So we want to make sure that we are keeping the muscle mass, losing the fat, and losing especially the visceral fat. That is one of the main risk factors for diabetes. And whether pre-diabetes, diabetic, or during that treatment, and also to prevent sarcopenia and also edema as well. So, sorry. So in diabetes, sometimes we used to use the circumference, the waist to hip ratio. But of course, when we check with the BIA, we can get a better idea that is deep, that will look at the overall fat, overall visceral fat, and at the same time, the edema, that we can use it as well. And one more thing, the skeletal muscle mass as well, as I said, because it's very important to make sure that we don't lose the muscle mass during the treatment. And of course, this is one of the main factor or main goals that we want to achieve from the nutrition plan that we apply for any patient, and especially during diabetic treatment. So pediatrician, and as I have explained in many slides before, we look at the interpretation of the spur of the large and fast growth for kids, especially when it goes through puberty, where we start seeing the fat-free mass and the fat mass changes rapidly during this period. So we want to prevent any hidden obesity during this period, instead of just treating it afterward, where the fat mass started accumulating. And this is where we can also make sure that we can plan a very well-organized and balanced nutrition plan for them, because at that age, we don't want to lose their, we want to get optimum growth for them during this period, and at the same time, if we have any extra weight, to help them lose it. So as I have mentioned, and many more other, if we have time, we can talk about it later on, but the BIA application is getting more and more important rather than just losing weight or just detecting the body fat. We want to use it in all our goals to get the proper caloric requirement based on the body composition rather than just a regular general equation, and to talk more body fat, body fat, body fat rather than just weight. The distribution of the fat is very important, health-related goals, muscle mass, and water. And we know also that these are the three most important components of our body: muscle, fat, and water content as well. These are the references, and I try to make it as fast as possible. At the end of the day, I'm sure everybody is tired, so I'll be happy to answer.
It's wonderful. Thank you so much, Mr. Zanshwehat, for the wonderful presentation. It was very informative, and it's always challenging to, make medical type of terminology sound familiar to the public. So that's a wonderful talk. We will leave the questions until after the last presentation by Dr. Amjad Jadar, and we will take the questions in one session afterwards.
Right.
Wonderful, thank you very much. Okay, so the last talk for today's session is about recovery meal, which is going to be presented by Dr. Amjad Jadar, who's currently working in as an instructor at the UAE University in the Department of Nutrition and Health. His professional experience includes 23 years as an instructor in three universities, and he has more than 10 years as sports nutrition consultant at Al Jazeera Sports Club in Abu Dhabi. He has published over 16 articles in peer-reviewed journals, and his research interest is sports nutrition, metabolic syndrome, assessment of salt intake, and glycemic index. Dr. Amjad Jadar has a master's degree in nutrition and food from Jordan University, and he's finalizing his PhD in the Faculty of Sports and Health Sciences at Oxford Brookes University in the UK. The floor is yours, Dr. Amjad, whenever you're ready, and you have 20 minutes on the clock. We can't hear you. I think you're muted.
This is not something new, as usual.
Okay,
thank you so much, Dr. Maisa, for this nice introduction. Thank you so much, the IGD conference. I'm so pleased that one of our role model or our alumni students is introducing me, and now she has a PhD. And I'm so happy that I can see you, Maisa.
Thank you so much.
We'll start now. Thank you so much. Today we'll talk about the recovery meal. So we'll go through, we'll go through the definition of the recovery meal. We'll discuss the substrate utilization during and post-exercise. We'll discuss the criteria of post-exercise meal, including the timing, the carbs, the carb to protein ratio, and we'll talk about the composition of the recovery meal. In the beginning, recovery is a complicated process. I don't know what's happened. Sorry. Yeah. Recovery from exercise is a complex process requiring the replenishment of body fluid, body fuel stores in terms of glycogen in the muscles, in the liver, replenishment of the triglyceride of the muscles working, in addition to control or repair the muscle damage. In order to do that, I need to shift the body from the catabolic phase into the anabolism phase. So my aim here to replenish the muscle and liver glycogen, to control the protein turnover that as a result of the muscle damage, to reduce the loss of muscle fat, and also to plan the fluid and the electrolyte replenishment. Because everything can be recovered except the fluid and the electrolyte, I need to plan it 2 hours before the events. So I can do the planning for the liver and muscles, everything, after But in terms of the fluid and electrolyte, I have to do it before the exercise, both or event. Now, this figure shows me the substrate utilization during exercise. This is the substrate utilization connected with the VO max, which means the maximum oxygen consumption during the intense exercise. If I look here at the moderate, which is considered is a mix of aerobic and high intensity exercise, that I see the main contributing factor or substrate used as a body fuel is the muscle glycogen, the muscle triglycerides, the free fatty acid coming from the adipose tissue and the muscle, plus the blood glucose. But also I mentioned something very important that I need to control, and not to prevent the muscle damage. As a result of the muscle contraction, as a result of muscle exercise nature or type, there is a phase called anasteric phase. In that anasteric phase, as a result of contraction of the muscle and involvement of exercise, the body will start to break down part of the protein as a response of this contraction. In addition to the hormonal change that will happen during exercise, the contribution of body protein will increase to be used as a source of energy, in addition mainly as a response of the muscle damage of the exercise. However, this is very important. The muscle damage does not stop once the event or the exercise stops. No, it will continue. It may continue up to 20 hours. It may continue more than that, depending on the nature of the exercise. What I mean by the nature of the exercise, some exercises require training for 5 times or 6 times per week, in addition to the big event, which is the game, for example. Unlike certain type of activity which require low duration with low intensity. So as much as the intensity increase and the duration increase, the recovery period and the muscle damage, I expect that will increase. However, in order to control that, several studies, they found that providing a recovery meal is very essential, especially if I choose the right time to give the recovery meal, if I choose the amount of carbohydrate that it should be consumed in addition to the frequent time, in addition the combination between carbs and the protein, and especially the ratio. So the goals here for recovery will be replenishing the muscle and liver glycogen stores, assist with the muscle to repair and control the protein turnover. And I will insist here, I will not able to prevent it, but I want to control it. And for me, as one working with the clubs, usually my target to maintain it to be 5%, not more than 5% as a loss, as a turnover. Restoration of fluid and electrolyte as a result of the loss of the sweat. And as this is what I mentioned, that it should be planned early, 2 hours before the event or the exercise, in addition to support the immune system during the exercise. Now, let's move to the body fuels and the store, and let's have an idea about these. If we look at the stores of glucose and the glycogen with the average 150-pound male, which has 1,800 calories of carbohydrate stored in his body. This is theoretically. Muscle glycogen will contribute to 1,400 calories. Liver glycogen will contribute to 320 calories. Blood glucose only 80 calories. Now, if I want to compare the capacity of muscle glycogen stores, well-trained athletes, they have the ability to develop more storage compared with untrained. And here there is a big difference with the definition between a trained and untrained. For us as a sport nutritionist, we want to measure the ability or the fitness. We can use the VO max as indicator. We can use the heart rate as indicator, in addition to the body composition as indicator to define that person is physically fit or not. In the past, it was better than now. Also, they were able to count the number of mitochondria. So if I'm well trained, so that's means the percentage of storage ability to muscle glycogen for me, it will be from 20 to 50%. So for untrained muscle, usually they have the ability to store 13 grams out of 100. For a trained muscle, it's almost 2.5 times, 332 grams. For carbohydrate loading, which is not advisable to use it more than or 2 times per month, 35 to 40 grams per 100. So why I'm focusing here on carbohydrate? Carbohydrates is not only considered as a fuel only for endurance exercise. No, carbohydrate, it has the ability to give me energy. It's considered as a standard golden fuel for my body with the availability with oxygen and the availability of oxygen. If I'm an athlete, I will spare carbohydrate to the end stage of exercise. Moreover, low carbohydrate diet will be associated with the chronically fatigue. So if I'm maintaining to take a low carbohydrate diet, also that will end up with increasing the fatigue. A study conducted by Costel et al. He did a study on a group of athletes on a 3 consecutive days. He asked the subject to run hardly for 10 miles, forth and back for 6 to 8 minutes per mile, and he took a biopsy. This is the good things of this study. They were able to take biopsy. They took biopsy in these 3 days, and they were comparing every day after. The pre-exercise and the recovery meal for the athletes was consist of carbohydrate, which was 45 to 50% of total energy. On the first day, the rate of carbohydrate or muscle glycogen, was 2 or above than 2. And the second day, it's become 1.5. And the third day, it's become 1, which means that my stores, my body fuel stores were reduced time by time as a result of taking recovery meal with low carbohydrate diet. Another study, it's very old, but it's one of the unique studies because in this study, again, they were taking biopsies and it was done on soccer team. They found that at the end of the game, which is almost 90 minutes, the players lost an average from 1 to 3.5 liters of water with average 2-liter water. They lost all the requirement of sodium, which was 5 grams. The muscle glycogen contribute almost to 200 grams per calorie. Liver glycogen contribute to 50 grams, and intramuscular triglyceride 50 to 100, and adipose tissue 50. But what is the important things here? After 15 minutes of the second match, or the half or the second half, most of the players reached the exhaustion rate before 30 minutes of the end of the game. So I didn't give enough glycogen loading, enough fuel in terms of carbohydrate for my players. So I left my players without any fuel for 30 minutes, and that will induce and increase the lactic acid production and the contribution of fatigue. Therefore, a normal pathway to recover the muscle glycogen is always take 5% per hour, which means I need 20 hours with complete rest and full replenishment in order to replenish the muscle glycogen, which means that I need to consume high carbohydrate rich foods, beverages within 15 minutes after the workload, and they need to maintain it every 2 hours. However, if I took the advantage that after the exercise board, I have hyperactivity in terms even of the hormonal and enzyme responses in my body, so I can increase the replenishment of muscle glycogen and even the protein turnover by a percentage from 7 to 8% per hour, which almost 1.5 the normal pathway. But that depending on the time when I will introduce the recovery meal. So recovery carbohydrate target is 0.5 gram per pound of body weight every 2 hours, up from 6 to 8 hours. So if I have an athlete, his body weight is 150 pounds, time 0.7, it will end up with 75 gram carbohydrate, which equal to 300 calories. The first study here will show the contribution of muscle glycogen synthesis after exercise. In this study, they were comparing 4 different times. They were comparing 0 time with 2 hours, and they were comparing 2 hours for 4 hours. They found that the group that fit at 0 time, which means at the end of the exercise bought immediately, they have highly significant rate of glycogen replenishment compared with 2 hours, and they found 2 hours is much better than 4 hours. So that will give me an indicator that as much or as soon as I do the recovery meal, I can guarantee well replenishment, or I can speed up the replenishment of liver and muscle glycogen. This study also is a good study, but in this study, they are doing a combination. They said, okay, what about the protein? What about if I give or I make a combination between carbohydrate and the protein? Because there is a fact, I'm not only losing carbohydrate, although carbohydrate is very important, or I'm utilizing the glycogen, also I'm losing muscles protein. So they did the research of the study. They selected the types of food. They claim it is low carbohydrate, although I believe it is normal carbohydrate. They give 1.2 gram per kilogram body weight. The second meal was 1.2 gram per kilogram body weight plus 0.4 gram per kilogram body weight protein with a ratio, remember that ratio is very important, with the ratio 3 to 1, and they gave high carbohydrate one, which is 1.6 gram per kilogram body weight. They measured the muscle glycogen, and again, they took biopsy. They took biopsy after 1 hour, and they took another biopsy after 4 hours. There was no significant difference between low carbohydrate, which was 1.2 gram per kilogram body weight, between high carbohydrate, which was 1.6 gram per kilogram body weight, and between the carb and the protein, which is 3 to 1 ratio. So they found the carbohydrate or the glycogen resynthesis or replenishment won't be affected. The good things of this study, they measure the leucine oxidation, which is used as indication of how much the protein is contributing to the energy synthesis during the exercise, but this is after, this is in the recovery. They found that at the first hour after the exercise, there was a significant difference in terms of carbohydrate in the beginning, but it was not high, but there is a significant, but after 4 hours, there was highly significant difference in terms of carbohydrate to protein compared with carbohydrate meals. When they calculated the net, when we come to the net, we will see how much I'm losing amino acid and how much I'm resynthesizing or replenishment amino acid. The two carbohydrate beverages, they are in the negative level. However, the carbs with the protein with the ratio 3 to 1 was on the positive side. And if you look during the first hour, which is high, the absorptive rate was significantly different. So that will give me an indicator. If I want to control and reduce the loss of muscle mass, I will use carb to protein ratio, or I use carb to protein beverages. And for me, I personally prefer to use 3 to 1. Now this figure shows the mixed muscle protein fractional synthesis rate, how much the protein is contributing to the synthesis of the muscles now. All of them, they are high, except the protein and carbohydrate is highly significant compared with carbohydrate high to low. So carbohydrate is good, but if I did a mix between carbohydrate to protein, it will be much better and will contribute more. At the end, an increased muscle synthetic rate and improve the whole body net protein balance compared with carbohydrate, that if I give a protein to carb with carb ratio, adding protein to carbohydrate also will be much better beneficial in terms of the muscle resynthesis. However, it will not affect the glycogen resynthesis, which is also good because there is no significant difference between them. The higher fixed synthesis rate during recovery could promote muscle adaptation during recovery from acute exercise by stimulating the synthesis and repair of the protein that facilitate the energy provision and force production. And this is my important and my rule as a sport nutrition. I need to control the muscle turnover. I cannot prevent it, but I need to control it with a certain percentage, because after that, if my players continue to lose more and more muscle mass, in this case, they will be easily fatigued and they will be easily get to an injury. At the end, the takeaway message here, the timing of the recovery meal is very important. Personally, I always tell my students that you need to give it within the first 2 hours, but If you can give it within the first hour or even 30 minutes, it will be much better. Carb protein ratio is very important and is not fixed. It depends on the muscle status of my players. So in the club, I'm using 3 different formula, and I'm sure Dr. Osama Lada is doing the same with his player. So we are not far away from each other. We are using different proportion. But the most important thing, and this is what we will discuss in the future with Tatqif, how you can be sure about the safety of the acid that, and this is very important thing. Thank you so much, and I hope that you benefit from this presentation. And any question, and I'm ready for you for any question. Thank you so much.
Thank you so much, Dr. Amjad. Wonderful presentation as always. It's very interesting to listen to you, especially when it comes to sports nutrition. You're very passionate about this topic, so it makes it like very interesting to hear about it. All right, so we're going to go into the questions now. We have our speakers for the session, and we have a few questions for each, but due to time limitation, we're going to take one question per each speaker. So let's start with Dr. Nasser Ibrahim. Somebody asked about using other types of protein, such as instead of casein, such as whey protein, or other types of legume instead of soy, that are more common in the Arabian culture. Would they have the same effect? And if you recommend, the second part of the question was if you would recommend stopping dairy for patients with kidney failure and adding soy with fish instead.
Thank you so much. This is a very good question. As you know, soy protein is largely produced mainly in the United States and in Brazil. So it's being used on a very high scale in westernized country. Yes, in the Arabic countries, we don't really use soy protein a lot. But the most important point about soy protein is the unique amino acid composition of the soy protein. The low ratio of methionine to glycine specifically make soy protein as a polypeptide that can be extracted from soy protein will have a very important effect mainly in reducing the progression of the disease. Also, soy protein has isoflavones in them. However, there are other studies that actually extracted isoflavone from soy protein, and soy proteins have the same effect. We did studies on the B protein polypeptides, and we have seen that the B protein have the angiotensin 1 converting enzyme inhibition effect. So it acts like an ACE inhibitors. So yes, a soy protein and B protein might have the exact same effect. We didn't examine the B protein on oxylipins, but on high blood pressure, yes, they have effect. On the casein, as you know, the main milk and protein is casein. We use the casein because this is the standard diet for animal studies. We need to have a standard diet so the international studies can be comparable. That's why we use casein. Casein is one of the worst protein, okay, especially in the effect of kidney. And one of the questions that we always ask, is it the casein that's really bad or the protein that's really good? Okay, but we have no options but to mix or to change the sources of protein and to see the effect of lipid. As you can see, the design was very complicated, the 4x4x4 design. It's the effect of lipid, effect of effect of disease. Okay, so very good questions. Can we replace soy protein instead of casein? I would recommend that, but we have to be careful with the estrogenic effect of soy protein. We don't have to use soy protein on a daily basis. Okay, and don't forget this is an animal studies. Before we convert these to human, we need to do some clinical trials. Thank you.
Wonderful. Thank you so much for your answer. We're going to move to another question for Ms. Razan, and somebody's asking about, actually a couple of people asked about how accurate BIA machines are, and what are the things that would affect the results, because I think somebody was saying that even with the exercising and dieting, it showed an increase in their fat and muscle mass. So what are, I'd say, what are the factors that would affect this?
That's very important. Well, basically, if we compare the results of the BIA to the gold standard, which is the underwater weighing, it will be the best one to come in turn. Of course, it depends on the machine. So there's no one number that is accurate for all the machines. But if I compare the bioelectric impedance in general to the gold standard, it comes as a first one after that. But as a number, it depends on the machine that you are using. And even from the same brand, there are different way of measuring that makes one of them more accurate than the other, depending on the number of electrodes that goes through it. As for the other part of the question, which is even with exercise and with diet, you see more fat rather than muscle mass, we need to look at, as I said before the test, the things to take into recommendation, which is no exercise before the test, for ladies not to be during the menstrual period, and also no food 4 hours before the exercise, then you will get a better result. But if you did all of these and you did not get the results, then you really need to change the exercise that you're doing or the nutritional plan that you are following, because then you are not getting the results from fat metabolism. Medically as well, we also need to make sure that we don't have any other medical related conditions that is affecting the fat loss, especially insulin resistance and thyroid as well as one of the main reasons.
Wonderful. Yes, exactly. There are many factors that could play a role. So they need to dig a little bit deeper to understand what's happening. All right, we'll take the final question. Thank you so much, Ms. Razan. Dr. Amjad, we have a very interesting question for you. Somebody's asking how to measure the muscle status, and also what would you recommend? Like, I think the question is, if you could give examples of post-workout meals, like how would that? So we talked about how the amount of carbohydrates available or the amount of protein and whatnot, but what would be like actual food that they could consume?
Perfect. I will answer. For respect to the muscle mass, I always say to my student and let's say my audience, that I'm using my background as clinical nutrition, and this is what we should do, all of us.
Mm-hmm.
And sorry, because I aging.
So how do we measure the muscle status?
Yeah, the muscle. Usually we are in the clinical, we are measuring the mid-upper arm circumference. We have two formulas. We have the mid-upper arm and we have the corrected. Usually we should use the corrected mid-upper arm circumference in addition to measuring the triceps. This is, allow me, Ms. Razan or Dr. Razan to say it, this is sharper and better than the bioelectrical impedance. Because at least with the sweating rate, sometimes it will be confusing and difficult to rely on the bioelectrical impedance. And usually I use it with my players, then I share the result. As I told you, as a clinical, we compare the result with the standard and we compare it with the growth rate. So at the end, we have percentiles. If you are checking Gibson or Niemann, you have the mid-upper arm circumference corrected and you compare it with the age and you compare it with the percentiles. At the end, I will compare it with average. I will compare it with below average. I will compare it with wasting. And this is the dangerous zone. And believe me, at least in any club, you will find 5 to 6 players that are reaching to the wasting zone. Of course, they are not reaching in the beginning of the competition, but in the middle and at the end. So my rule here, to delay the onset of wasting or to keep a barrier or a safety zone called the below zone. This is what I use. Now, what you will be surprised at about the sport and nutrition student, what they are doing in UE University. We are using ice cream with, I will tell you, I prefer to use the medical formula in terms of the protein because it's very safe, unless I have a commercial formula that is approved by a third partner. So usually what I do a combination like what you are doing in exchange list. I use the fruits, I use juice, I use the protein, whether I'm using from Abbott, I always use it from them, from Abbott or from other company, for example, from Bene protein, I use it because I use also fruit salad with the protein. I calculate the ratio of protein to carbohydrate, and the good things, I make it good presentation and the flavor is acceptable. So when you introduce it to the player, you introduce it in the form of cocktail, or I introduce it in the form of fruit cocktail, fruit salad, sorry, or I introduce it in terms of ice cream. Because the last group with the sport and nutrition class, they did a nice ice cream with this ratio. So it is very challenging, but yes, they believe me, they are an excellent student. I think they are attending now, and I use their videos in the practical work. So the ratio is not difficult. You are using your skills as a nutritionist or as a dietitian, and you are only doing a simple calculation. But as I told you, I'm using the medical protein because it is my rule to make sure that these players, they will have a safety product. And from my side, I will also save myself that I will not give them not approved by the Ministry of Health or not approved by the FDA.
Of course, they are your responsibility after all.
Yeah, actually, yes, indeed, we can use as well the biceps and the triceps measure, but it takes well-experienced and well-trained professional to be able to do it, because there is a big human error in it, especially really getting the right result out of it. So definitely it is an excellent, especially when it's done by yourself. So for sure,
Wallah, believe me, Razan, believe me, Dr. Razan, Wallah, believe me. When the student in level 2 and level 3 in your university, and I'm sure even other universities, but the difference, we give the chance for our student to handle the caliber, to use the caliber, you know, because I remember when I took the caliber first time with Dr. Hamid Takruri, it was something strange. When I grabbed the skin fold thickness, it was totally strange. And when my first time, I touch and I grab for a female, I found, wow, this is a huge difference between the female and the male in terms of the skin fold thickness. But, you know, after experience, it's become easily. You know, our students, what they are doing comparison between the skin fold thickness. They are comparing the 2-segmental tenita with 4-segmental tenita. They are comparing M-body, they are comparing Sika, and they are comparing DEXA. Why they are doing all that? Because we need to explore them and to be familiar about different type of measurement. So whenever they will go to any setting, and like what you explained today, they want to go for any measurement, they need to understand the principle of the machine. And this is our rule. And I think even the others, they are doing the same.
100%.
But it's needed practice. But if the student or anyone didn't practice that, he will think this is something wow, something big or something difficult. But believe me, it's only a practice.
Absolutely, just like calculating multiplication or using calculator.
Yes, you're right.
All right, I'd like to thank all of our speakers for this session. Wonderful presentations, really, really informative. At the end of this session, I also would like to thank the organizers from Tatqif and in particular Ms. Kim for organizing everybody and the time and doing all the efforts in this. Before we leave, we just want to take a group photo for the entire, for the speakers of this session. Okay. Ms. Kim?
You will share with us the picture, or خلاص we can take it?
Ms. Kim is going to share, Ms. Kim is going to share the picture with us.
I will share. All right, so please see on your camera in 1, 2, 3. All right. Thank you. I'll send it in over the WhatsApp.
All right, wonderful. Thank you very much, everybody, and thank you for your time.
Thank you so much.
Thank you very much.
Thank you so
Have
much.
a good night.
Thank you.
Thank you.
Have a good night. Ms. Kim, the floor is yours.
Thank you so much.
Thank you so much. Thank you, everybody. And amazing, wonderful. Thanks a lot.
Thank you, Dr. Leila.
All right, thank you to all attendees for today's first conference. We hope to see you all tomorrow, same timings at 3 o'clock in the same link, in the same platform link. Our exhibition hall is still open up until on the coming Friday. So any one of you would like to communicate with any of our sponsors, their booths are with a chat functionality. You can click it, and please don't miss out our important session for tomorrow. which will be given by famous speakers. We hope to see you all tomorrow. And if you have any further clarifications, please feel free to send us an email or a WhatsApp message. Thank you, everyone, and have a safe evening.